Welcome. My name is Quinton Gopen. It is my honor and pleasure today to talk to you all about semicircular canal dehiscence. So feel free to ask us questions through Twitter or Facebook on the links posted on the slide next to me. I'd like to thank my partner, Dr. Isaac Yang, through which his help made this all possible. A great person and a delightful colleague to have. We have no disclosures for this lecture today. So let's talk a little bit first about the history of semicircular canal dehiscence. It's a relatively recently diagnosed condition. It was discovered by Dr. Lloyd Minor, and he presented a small series of patients that had failed surgery for hearing loss, and that was back in 1998. So let's talk about what is semicircular canal dehiscence. In your body, you have three perpendicular balance sensors that are deep inside your head encased in bone. And the condition of semicircular canal dehiscence is essentially bone that's missing over the canal that points directly upward. And we'll review that with some slides and pictures. This defect in the bone is very tiny. It's usually slightly less than several millimeters in size. So what are some of the symptoms that you could expect with semicircular canal dehiscence, which I'll abbreviate as SSCD throughout this talk? So you're going to get varying degrees of hearing or auditory dysfunction and balance or vestibular dysfunction, amongst other things. So first we'll talk a little bit about what are some of the hearing dysfunction symptoms that you might have. So you can see on the slide next to me, hearing loss can be broken down to different types. One is a mechanical type termed conductive. One is sensory neural, which is when the organ of hearing itself is not working properly. And in canal dehiscence, the most common type is mixed, which is a combination of both of those types of hearing loss. So in addition to hearing loss, you're going to have tinnitus, which is the abnormal perception of sound. It can be either your heartbeat or a continuous noise. And then hyperacusis, which is the medical term for when loud sounds are bothersome. These loud sounds can be quite irritating to patients. On the right, you can see the internal amplification of noise. That's sort of a hallmark of canal dehiscence. Not everyone will have those symptoms, but the majority of patients will have some internal amplification of sound. So you can see on the list next to me, autophony, which is when your voice is perceived internally when you're talking. You can hear your heartbeat inside your head, your eyes moving, even digestive sounds, chewing, walking around. All that stuff is internally amplified in this condition. So vestibular or balance symptoms that present with canal dehiscence can be divided into those that are with provocation and without provocation. So these can be just varying degrees of off balance or disequilibrium or true spinning vertigo. And when it's with provocation, it's typically with either loud sounds or with pressure events, either intracranially, meaning inside your head, or with straining or other activities that increase pressure. And finally, oscillopsia is a term when you walk around, you can't focus on things. It's called the jumbling of the panorama because your balance system is crucial towards focus. And when you lose that ability, it becomes very difficult to walk around and function properly. The next slide covers some of the nonspecific symptoms that are present with canal dehiscence. And these are less specific to the disorder, but as you can see on the list, things like ear pain, earfulness are very common, headaches and head pain. Some patients describe what they call a brain fog, where they're just sort of thinking in a fuzzy sensation. Some varying degrees of memory loss and problems with fatigue are very common with this condition. So epidemiology, this is a condition that can present at any age. It's most common in the 5th decade. There have been some pediatric series that have been reported, and it is considered normal to have missing bone over the balance channels if you're younger than 6 months of age. There are some weak associations with osteoporosis, with head trauma, and with extreme straining such as childbirth, but for the most part, we don't understand what causes canal dehiscence. It's an unknown etiology in terms of its causality. So let's review a little bit about how you can make the diagnosis of semicircular canal dehiscence. And in my opinion, the best test is going to be a CT scan of the temporal bone, which is the medical term for your ears. So a fine cut CAT scan of your ears is going to show that missing bone area quite well. I've put on the slide next to me, some people ask about MRI. MRI is sometimes considered to be better than CT scan, but not for looking at bone. MRI scan actually doesn't show bone at all, and so an MRI scan will not detect the canal dehiscence like a CAT scan will. So you really want a fine-cut CT scan of the temporal bones. You don't need any injection of contrast dye for that scan. There's another test called the VEMP test that we'll touch base on, which is a non-invasive test that can confirm the condition, but I consider the CT scan to be the gold standard for making this diagnosis. So let's review some CAT scans. The following slides are going to depict a example CT scan going from the front of the head back in consecutive slices, and I'll take you through that. Those are called coronal or upright views. So here's the first scan that I'm going to show you. On the CT images, the bone, which you can see as the white structures, the skull bone, and the floor of the skull, which is called the tegmen. You can see the black area, which is coming into the ear canal from the side. That's if you stuck your finger in your ear canal. And then the gray structures up here is going to be the brain tissue. Any fluid is going to look gray on the scan. This little snail-shelled type structure here is going to be your cochlea. So the balance chambers are going to live behind that. So as we click with each consecutive slice, you're going to see a little further back, and we can start to see some of the semicircular canal. So the green arrow right now is over where the superior canal is going to come into view. So you can start to see it a little bit here coming into view on this first section. So I'm going to go to the next slice, and you can see the green arrow pointing to the superior canal quite nicely. It should be covered by a nice little white cap of bone, and on the example shown you can see there is very little to no white covering of bone over where that arrow is pointing. So that is a dehiscent superior canal. We're going to go through these sections. You can see it becomes even more obvious. There is no white covering over that canal where the green arrow is, and we're going to follow this through the entire sequence of images. Remember, the semicircular canal is a semicircle, and so you're going with each section over the dome to the backside of the canal. So here we are at about the apex of the canal, and you can see there's very little bone covering that opening. And as we get more towards the backside of the canal, you can see here, this section shows a normal covering of bone over that canal. So that's what it should look like along the entire series of images. But as I showed you in this particular example, most of those images did not have that white covering of bone over it. So that is an example of semicircular canal dehiscence of the superior canal. So there's another view that you'll come across if you do a little bit of homework on this called the Pauschel's view, and that's a view where you're imaging in the plane of the semicircular canal itself. So you're trying to capture the entire canal in one view. It is not required to make the diagnosis, but it just is a nice summary of what the patient might have. And you can see here where the green arrow is, the entire canal is now depicted on this scan, and you can see there's no bone over the entire dome of the semicircular canal here. Let's talk a little bit about VEMP testing. VEMP testing is vestibular evoked myogenic potential testing, and this is a non-invasive, basically a hearing test where you're looking for a normal reflex that all patients have. So the normal reflex is when you put a loud sound into your ear, you're going to get a reflexive contraction of some of the muscles in your neck, and that has to do with postural reflexes. In semicircular canal dehiscence, that reflex gets greatly exaggerated. So you're going to see it at a lower volume of sound, and the reflex in terms of the contraction of the neck muscles is greatly exaggerated. That test is pretty specific for canal dehiscence. It can be useful for ruling in or out conditions, cases where maybe the presentation isn't so straightforward or the symptoms are not consistent and you need a little more information. I would say in my experience, if the symptoms are classic for the condition and the CAT scan confirms it, the need for VEMP testing is not crucial, but it is offered at UCLA amongst other centers and can be helpful in certain select cases. Another point of fact about VEMP testing is that it does normalize after a successful repair. So once the repair is done, that reflex should get back to the normal response. So you can see in this slide next to me, on the right we have the normal response. You can see on the lower line there, 70 decibels. It's pretty flat, so there's no response. The response is going to be this peak and trough that you can see on the right. So at 75 decibels, there's really no response. At 8 decibels, you can start to see a little bit of a peak and trough. And at the top tracing at 90 decibels, which is a pretty loud sound, you can see a nice peak and trough response. And so that's the normal response on the right side at 90 decibels that is not present at lower volumes such as 80 or 70 decibels. on the canal dehiscence patient here depicted on the left, you can see a very robust response at 90 decibels, and it looks like it's a little smaller peak and trough, but if you had the right amplitude markers, you would know that that's actually a much bigger response than the one on the right side, the normal patient. And then as you go down in volume, you can see the response is still present down almost to 45 decibels here, it's gone, but at 50 decibels, it's still present. And so 50 decibels is a much softer sound, and you're still getting a response in the canal dehiscence patients. So let's talk now about your treatment options. You know you have canal dehiscence. What are your choices going to be? There are very limited medical options, unfortunately. So you can have some symptomatic treatment for your dizziness, some dizziness suppressing type medications, but as a general rule, there isn't a lot besides physical therapy that you can do, and that is a variable success in this condition. So most of the treatment options of choice are going to be surgical in nature. And we're going to review today the three most common, or the three main treatment options surgically in this condition. So one is going to be the round window repair, another is going to be the transmastoid approach, and then one that we prefer at UCLA is going to be your middle fossa approach. So in terms of the different approaches, the round window reinforcement is basically an approach that's done through the ear canal, through the whole of your ear. The mastoid approach is done from behind your ear and you go through the bone, and the middle fossa approach is made with a small window in the skull bone from above. So we'll start with the round window procedure. So this is the least invasive. It's basically just going through the ear. You go down into the ear canal skin and push the eardrum out of the way. That gives you access to the round windows. Let's talk a little bit about what this all means. Well, when you think about your organ of hearing, there's a normal entrance for sound to enter into the inner ear organ, and that's called your oval window. And the sound energy then flows to your inner ear organ and exits at something called the round window. When you have canal dehiscence, there's another additional abnormal opening into that system that shouldn't be there. And some people refer to that as a third window. So if you see third window, that is another way of describing semicircular canal dehiscence. So before semicircular canal dehiscence was discovered, there's another condition called perilymphatic fistula. And what that is a leakage of the inner ear fluid out of the inner ear organ. And that can happen from various types of trauma, fractures, or extreme pressures like scuba diving. And when that happens, you get a lot of the same symptoms that you get in canal dehiscence, like dizziness, fluctuating hearing loss, and other symptoms that can be similar. And so prior to 1998, when this condition was discovered, some patients that were misdiagnosed as having perilymphatic fistulas that actually did have canal dehiscence underwent this round window repair, which is a way of sealing off the inner ear for patients that have perilymphatic fistulas, and anecdotally some of those patients would get better. So the way I describe it to patients is you're basically changing the dynamics of the inner ear, and there should be a normal entrance and exit. And when you have canal dehiscence, there's now this abnormal opening. By repairing the exit, you're changing the way sound and balance energy is going to flow through the ear. Sometimes that's helpful and patients can get better, but sometimes it's not and patients can actually get worse. So it's variable, it's hard to predict, and it's not a true repair of the condition. So it's not favored here unless the patient is too sick or medically frail to undergo the definitive repair for the surgery. So let's talk a little bit about the data on that. There was a small series done by Dr. Silverstein in 2014 that showed about 19 patients that had some degree of symptomatic improvement, but a more aggressive sealing off of that exit point, which is called the round window occlusion, the patients got worse. So the next approach I'm going to talk about is the transmastoid approach. And so this is a small incision behind your ear. The bone is then drilled off over the mastoid to give access to the canal. This is really an approach from below, so you cannot see the opening directly. It's an indirect view, and as such, it makes it more difficult to repair the dehiscence. Now, some of the proponents of this approach, and this is an approach that I do offer patients, but is not one that I favor, say that it's less invasive. I disagree with that statement, and you'll see part of that is because of what we've been able to evolve with the approach from above here at UCLA. But you have to drill a fair amount of bone off to get there, and then once you're there, you still need to either lift the lining of the brain off of the defect, which is done, again, in an indirect view, or you have to drill open the inner ear itself to plug it. So whether you're going to resurface it or plug it, which we'll get into in a little bit, I don't consider that a minimally invasive thing to do to the ear, to take a drill and drill into that organ. So again, it's something that we offer patients, but we usually steer them towards our more reliable technique which is going to be your middle fossa approach. So this is the standard approach that we have used here at UCLA. It is an approach from above, so it gets the best direct view to this dehiscent area. And so you're talking about an incision on your scalp and a window being made in the skull bone. We use Neuro Navigation. We use a special kind of homebred fusion image between the CAT scan and an MRI scan to give landmarks that really makes it quite precise. So we have been able to refine our surgery to be minimally invasive with precision, using these advanced technologies to be precise and know right where that opening is going to be, so we don't need to have a larger exposure to do that. We can measure the depth of the dehiscence very precisely on the preoperative imaging, and for almost all patients, it's about 1 inch deep from the outer skull bone. So on the left, you'll see a more traditional standard middle fossa approach. You can see it's a pretty large incision encompassing a lot of the skin on the scalp, a lot of shaving, so it's more difficult to heal from this. It's a longer procedure, but with the assistance of my great friend and colleague, Dr. Isaac Yang, he's been able to evolve the approach to be a much more minimally invasive modified incision, which you can see there on the right. And so I counted, I think, 8 staples that are used to close that incision. It heals very nicely, there's less shaving. And through that incision, we're able to make the little window in the bone quite precisely to get down to where we need to be. So I brought a little visual aid here. I have to say that I had to carry this through Westwood, which I got a few interesting looks as I did that. It was about a mile walk, and I really couldn't hide it. But anyway, my little skull here, I tried to draw on the side of the skull how we make that opening in the bone. So you can see on the skull, I've drawn a little circle where the location of the bone that's going to be removed is, and that circle is 1.5 centimeters, which is our standard size. So you can see it's slightly smaller than my thumbnail, and we can do the entire surgery through that very small little opening. And so if you look inside the skull here, the area that we're trying to get to is right here. It's about 1 inch in from the outer skull bone, and that's where the superior canal is, and that's where the little tiny opening is in the skull bone, causing all the trouble. So on the slides next to me, you can see once we start the surgery, we start to mark it with these lines here. So this line, which we affectionately term as the line of Yang, is an extension of the cheekbone going over here. And then this line perpendicularly has my name attached to it, and it goes right in the middle of the ear canal, which would be around this area here. So using the intersection of those 2 lines, we can very precisely make that small 1.5 centimeter opening in the bone, which you can see on the picture on the right. And that gives us all the access we need to repair this. The surgery is very streamlined at UCLA, so our average surgical time is right around 90 minutes to do the entire procedure from the initial skin incision to the closure. And we consider this a minimally invasive keyhole approach to the repair for semicircular canal dehiscence. So there's a lot of discussion when patients come to see me and in the internet and literature about plugging versus resurfacing. And I think some of that is marketing, but essentially resurfacing is when you're covering up the abnormal opening with various types of tissue, whereas plugging is you're actually smushing stuff into the actual canal. The problem with plugging is that by obliterating that canal so that there's no longer any fluid that can flow through it, you're really removing its functionality, which is not devastating to patients. They overcome that, but you've now removed the superior canal from the balance abilities of that particular patient. The problem with resurfacing is it doesn't often give a watertight seal. So as much as you're passively covering that, it's not giving you that nice watertight seal which you want for the repair. The literature, kind of the jury is out. So there are plenty of studies that show that either of those 2 techniques is reasonable with good results. In fact, some people think just by lifting the lining of the brain off of the defect, you're fixing the problem, and then whatever you do at that point doesn't really matter because the scar tissue forms and patients are better. But most that do this surgery are going to put some type of tissue in there to help seal off the canal. And that's what I try and do in my mind, is I'm trying to seal the canal without obliterating its functionality. Whether you want to call that a canal sealing technique or a partial plugging technique, that's what I try and do. And the list of tissues that have been used on this slide, you can see are very diverse. So fascia is the lining of muscle, Cartilage has been used. Even ground up bone from the patient called bone pate has been used for this. A lot of patients ask me what bone wax is. Bone wax is kind of what you'd imagine. It's a waxy type material. It is by far my material of choice for using in these cases. So I was able to, don't tell anyone from UCLA, steal a little bone wax from the OR today and show it to you here. So this is a little packet. And so it's about what you'd expect. It just looks like a little block of wax, and you can break it off very easily and mold it to whatever configuration you want and make it whatever size you want. It has a kind of a tacky, sticky substrate to it, and so you can push this in and it stays put. This has been used since World War I. It's almost unreactive to patients, and so when you go back, there's very little to no reaction to the bone wax, and patients have had this in their body for many, many years without any issues, and so I like it a lot. It's a very good material for repair. The weakness of bone wax is that it does not show up on post-op imaging, and so if there is an issue with the patient and they didn't get better, it's hard to tell what the repair is like on the post-operative imaging. So other materials, bone cement, I don't particularly like that. It's very hard, brittle material that can on occasion get infected, and it's very difficult to remove, and it doesn't in all cases give a nice watertight seal, and so I actually have over time migrated away from bone cement, although it does give nice post-operative pictures. And then various biologic glues and other materials have been used for this purpose. So at UCLA, with our middle fossa approach, the minimally invasive keyhole approach, we have now, over the past 4 years, performed over 120 cases. And our statistics are as follows. As you can see on the slides, the vast majority of these people, greater than 95%, have resolution of those internal amplification of sounds. Ear fullness resolves in about 70% of patients, as do balance symptoms. I should warn patients that if you have this condition on both sides, your recovery is going to be a little longer and the statistics aren't quite as good, but they're still very reasonable. And then hearing loss. Well, hearing loss doesn't get better in all patients. In fact, it only improves in a minority, 15%, but it stays the same in the vast majority. So around 70% of patients will have the same hearing, and we monitor hearing very closely during the surgery. So 85% in total are going to have the same or better hearing, but 15%, which is not a tiny number, are going to actually have some worsening of their hearing. And no one has lost all of their hearing from this procedure, but there have been a few patients that have lost enough hearing that they're frustrated with new tinnitus and other symptoms. So the average hospital stay is 2 days. The first night is in the ICU by protocol. Just for safety, we have a world-class neurosurgical post-op ICU hospital here at UCLA where we park our patients for the first night. We do feel it's okay to fly after surgery, so many of our patients come from remote distances. We've had patients from all around the world come here, and we do clear them to fly when they want to after surgery. Most of the patients stay about a week after surgery, but some stay longer. We take the staples out 2 weeks. You can either do that locally if you're back home, or we'll do that for you here if you're still here at the 2-week mark. And then we advise against any strenuous activity for about 6 weeks, and then vestibular rehab. I don't universally prescribe that for all patients. If you need it, we do it. You can do it at any time. I usually try and hold off for a couple months just to let people get a little more stable and see if they really need it or not. So what are some of the complications of the surgery? Well, headaches. Everyone has a little bit of, maybe more than a little bit of pain from the incision, and that goes away pretty quickly. People complain about chewing issues for a few days after the surgery, but those are very temporary. So the headache complications, when it's persisting for more than a month and it's pretty extreme, that happens about 5% of patients. If you've had prior head trauma or you have this condition in both ears, a little higher incidence of that happening. Spinal fluid leaks, that's when you get a little rip in the lining of the brain. So I should say that the entire surgery is done without going into the brain compartment. We're on the other side of the lining of the brain. We're just lifting up that lining to get to where this bony defect is, so we don't need to go into where the actual brain tissue is on the other side of that lining. But occasionally we get a little rip or tear, and then the fluid that surrounds the brain called spinal fluid leaks out, and that needs to be addressed. Usually it can be sutured closed, but if not, we have to put a little drain in the base of your spine to divert the spinal fluid for a period of 5 days in the hospital, so you're in the hospital a little longer if that happens. And then we have had a couple patients with delayed facial weakness after the surgery. So when they wake up from surgery, the facial nerve is fine, but a few weeks later, their facial nerve becomes a little weak and they can't move it properly. And when that has happened, it's been very temporary, and the resolution has always been back to normal in a timely fashion. So what are some controversies that we can talk about? Well, we'll just talk briefly about if you have this in both sides, how long do you have to wait? So some people want to have this surgery on both ears at the same time. Well, that can't be done. That's not recommended. So the minimum time that we wait between the two sides is 6 weeks. When do you start vestibular rehabilitation? Again, I touched on that a little bit. You can start it whenever you'd like. I usually try and wait a few months before we start that. So the general 6 weeks to 3 months is kind of my time frame for that. And that can be very helpful in getting patients to be better. And some people have tried vestibular therapy or rehab before they've had surgery. And my example is that's like walking on a leg that's broken. Until you have the leg fixed, you can't really expect to get a lot of improvement. So even if you've tried vestibular rehabilitation before surgery, have an open mind. It might be much more successful after the procedure. What about thin bone? So some people don't actually have an overt opening in the bone. They have a thin plate of bone. And over time, we've learned that people can be very symptomatic with that thin bone, and they actually do quite well with the surgery. In fact, their ear is at less risk to have some of the complications like hearing loss. And so we do offer this surgery to patients that have very thin bone. Now, if your bone is healthy and normal, you don't have canal dehiscence. There's no purpose in doing a surgery that's not going to work. But if the bone is paper thin, you'll likely have some benefit from the procedure. In summary, I'd like to say that superior semicircular canal dehiscence is a relatively newly discovered and rare condition that comes from having an abnormal opening into the inner ear. It is something that we offer a streamlined, keyhole, minimally invasive procedure here at UCLA with very good results. We consider it the standard treatment and repair for this condition. I would remind anyone that has questions to feel free to try and contact us through Twitter or Facebook, or if we don't have time to answer your questions, which we'll get into, you can always feel free to email either myself or my colleague, Dr. Yang. So we'll take a moment to do some questions here. Thank you. So the first question is SSCD surgery at UCLA covered by insurance? And I would say universally it is covered by insurance. It is not a cosmetic procedure. It is absolutely covered by insurance. Is there anything that covers the keyhole window in the skull after surgery is done? Yes, there is. So we put a little small titanium plate over that. It's not one that will set off any metal detectors at the airport. Technically, it can be removed after the healing has occurred, but usually we just leave it alone. Is it safe to scuba dive with this condition? I would say no. When you're scuba diving, you're in a potentially dangerous situation underwater. If you start to get dizzy due to the pressure issues, you're not going to be able to surface, and it could be potentially life-threatening. So any of the other questions that I didn't get to, feel free to just send me a direct email. I'll be happy to try and answer them for you in a timely fashion. Again, it was my pleasure to give this talk, and I look forward to doing more of this in the future. Thank you.